Well, welcome everyone. I think I'm going to try to follow with Dr. Page's starting on time mantra, but not before time. And so first, I think Brian Lewis is down here in the audience. I want to thank him for an exceptional job of introducing our Grand Round speaker last week when I could not be here. So, Dr. Lewis, thank you very much. So we have a great topic for Grand Rounds today. It is something near and dear to my heart, which is practice transformation. And we have Dr. Marcus Friedrich, who is the Chief Medical Officer of the Office of Quality and Patient Safety in New York State for the Health Department in Albany, New York. So we're very lucky to have him here. He's actually a primary care physician by trade, and he did his medical school at University of Miami, Miller Medical School in Miami, Florida, followed by his residency in internal medicine at Lenox Hospital in New York, and he and Mark Jeckett met each other when they were in Boston. So he has done work in primary care transformation, and his work with sepsis on a statewide level is what he's here to talk about today. And I think when we think about transformation and quality of care and population-based work, you know, we do a lot of that here at UW. We do it as an institution, but some of these programs that are statewide are really fascinating and interesting, and we're very lucky to have him talk to us about that. So please come forward.
Thank you.
Welcome.
Thank you very much. Boy, yeah, it's good to be back. So I actually know Madison. I've been here through a rotation when I was a medical student many years ago with the orthopedics department, and spent about 6 weeks here with Tom Zedeplik and the whole team. So it's great to be back here in Madison, and it's interesting to see that the weather is as crappy as in Albany. It's very funny to say that. So I'm Marcus Friedrich. I'm a primary care physician. I work in a HIV primary care clinic in Albany, but my main job is in the Department of Health. New York, as you might know, upper right corner of the nation. We have about 20 million people. The health department is one of the largest in the whole nation. There are about 5,000 people working there. We also are an insurer. We run the state Medicaid program as well. We have about 10 physicians overall, which is almost insane thinking about it, how underqualified the clinical leadership is in the department. But nonetheless, we're doing like great projects. And Betsy mentioned, like, my main job is in the primary care transformation arena, but I also do sepsis and stroke. And I'm here today to talk about sepsis in general, and really it's not only about sepsis but also about change management, because the lessons that I will talk about today, what we installed in New York on a big statewide level, I feel you can also take those into the hospital and also even in your clinical teams and think about how to approach sepsis. And I heard that you are also undergoing a new project about sepsis, so this might be helpful at the right time. I have no disclosures. I work for the health department. They don't allow me anything besides that. And really, the main take-home from today is really these lessons that we learned, and lessons about change management in general, thinking about how can we apply this really difficult thing to to our clinical programs. So my talk, I divided it up. Like, I first want to give you a little bit of background about, the sepsis situation in New York. And then I want to talk about kind of our three-pronged approach, talking about public reporting. I want to talk about quality improvement. And I want to talk about some research agenda. So this was the situation back, if you go back 8 years ago, 2010. We looked at data. We concentrated, whenever I talk about sepsis, I just want to make it sure from the very beginning, I'm talking about the severe sepsis and septic shock piece of that. 50,000 patients every year, and the mortality rate overall was about 30-35% in the state. Then we said, wow, this is a high mortality rate, really in New York, like even in hospitals, that high. And then we looked even deeper, and we looked at raw mortality from hospitals to hospitals. And this is like was an amazing lesson. There was such a variation. Like some hospitals had a mortality rate of 10%, other hospitals had a mortality of 60% of sepsis. And we say, how can this be? I mean, there is enough evidence out there, even by 2010, that there are, guidelines, standards of treatments, bundled treatments. There were a bunch of really important papers out there. So why is there such a big variation? And then, there was also some national interest, the Stop Sepsis campaign, just like promoting the work that they've been doing. And then in 2012, there was a tragic case. Rory Staunton, maybe you're familiar with that, like a 12-year-old kid who fell on a basketball court, ripped his arm, got a little wound, got home, felt a little bit bad, under the weather, went to his primary care physician. They sent him home and said, yeah, it's probably a stomach bug. Then he got sicker and sicker, went to the hospital. In the ER, they took blood, but nobody followed up with the blood. By then, he was already febrile and showed the signs of sepsis. They sent him home. Then overnight, he crashed at home. They sent him back in septic shock, and he died 2 days later in the hospital. Really tragic case. Would have been another septic case. Nobody would have noticed, but the parents actually had a friend at the New York Times, and they wrote that up. And, it created a huge outrage in New York. And therefore, we kind of all were, in shock. And so what does the department do? If you're seeing all these, background story, what is kind of the next step? There is really, one of the things in change management is also kind of thinking about, the need for change. And there is also a sense of urgency, and that was clearly at this point what we saw, that something needed to change. And so whenever state health officials don't know what to do, the main thing to do is actually call people in and get a summit. And so we did a big sepsis summit in 2013 and showed hospitals the data and said, can you explain to us why is there such a variation in hospital mortality? I mean, these are evidence-based protocols. Why are you not applying these protocols? There should be some variation, but not from 10 to 60%. And nobody could really explain it. And after a whole day of deliberations, actually the former Commissioner of Health stood up, slammed his hand onto a table like that and said, okay, enough. I heard enough. I will now make it mandatory for every hospital to have sepsis protocols in place, not only for the adult population, but also for the pediatrics population. Secondary, I want all of you guys to train your staff, frontline staff in the hospitals on sepsis recognition and also the timely treatment. And then third, I want to get the data from you guys because I want to see how you're doing. Huge outrage from the hospital community and from the physicians. They say, how can this be? The department is telling us what to do, how to treat our patients. It was nothing further from the truth. We actually just wanted to have these protocols in place for the hospitals. And really the hospital associations who are in any state, I don't know how here in Wisconsin, but are the big elephants in the room, there was really no argument. Nobody could explain this huge variation. And hospital sepsis protocols seemed like a really good idea. So this is what we put then in place in 2013. And again, the reason why we went the way with regulations, it gave the department some authority, but it also brought together different stakeholders because suddenly, hospitals were talking about it, hospital administrators were talking about it. Suddenly funds were available in hospitals to do the necessary change management, to think about processes from when the person got into the emergency room all the way up to the floor, even in the ICU, where before sepsis was treated and it just happens. So that was kind of like, we were the first in the nation, huge articles there. And New York, just as a background, is a very progressive state. We were the first state starting public reporting on the cardiac side. In New York, everything that you want to change in your hospital has to go through a certificate of need program. So we are really having like a pretty tight grip on the hospital community. And this was overall seen positive in New York, but it created a lot of backlash in the medical literature, and this is going on till this day. So again, sepsis protocols, when I talk about sepsis protocols, this is from a paper that just came out in the Blue Journal about the different types of protocols in New York. Here, how do you identify sepsis? Just on SIRS criteria, it's just one hospital. The biggest one is this positive sepsis screening from clinical assessment, meaning that you'd use SIRS, but you also can use lab values and the clinical assessment to make an assessment of the person in sepsis. Then about 26 hospitals, you had to have abnormal labs to be septic. This was the difference between this bucket and this bucket. And then in 23 hospitals, they installed like a rapid response or some kind of code sepsis. There is some data around how these different ways of how protocols got initiated in the hospitals, how these work in terms of mortality. But I just wanted to show you that we didn't tell the hospitals, this is how you had to do it. We only said in the regulations it had to be evidence-based, had to be on the recent guidelines, and you were almost free to do what you wanted, but we also checked the protocols. So they sent us the protocols, and we made sure that they were fulfilling all those guidelines. And then the next step in change management is create a vision. And our vision was 50% reducing the mortality. This is not from me. I mean, this is hard and quality improvement. 50% reduction in mortality. I mean, the only positive thing is there was no time associated with this, but 50%. This is a lofty goal, and I will talk through, where we are now on that vision here. So what did we do? I'm a primary care doctor. I learned about sepsis a little bit during my residency, but I am not a specialist. And so we tried to surround ourselves with smarter people. So we created the Sepsis Advisory Group, not only from New York, but also outside New York physicians who are really experts in the field. We developed a data dictionary, and we developed this data collection piece, and we collect clinical data on 70 variables, mostly about treatment, severity, comorbidities, and so forth, that the hospitals are giving us on a quarterly basis. We also thought about the pediatric piece, because that was important, not because only of Rory Staunton, who was a child, but we thought that sepsis also happens in children. And as you might know, that sepsis is well researched in the adult population, and they're just getting into on the pediatric side, and there's a lot of controversy still. We started in the second quarter of 2014, and then we gave hospitals the ability to correct the data. So it's a big data portal. So if something changes, staffing or so, they can go back and make sure that they input the right data. These are some of the bundles that we put forth at the Sepsis Advisory Group, and we agreed on. This is nothing new. If you read, sepsis guidelines, you will see elements of this, but you had to measure somehow, and sepsis is really hard. It's easy to measure blood pressure. It's easy to measure hemoglobin A1C, but how do you measure something as hard to define as sepsis? And so we kind of thought about interventions and how to measure kind of the treatment, and we developed these bundles. I'm not going to go more into detail, but the main ones are the 3-hour and 6-hour bundle. And then on the pediatric side, we kind of thought about or developed this 1-hour bundle with these interventions at this time. And then the next piece, also in change management, after the vision, is communication. So if you just keep all the data inside, it would not make any sense. So you got to turn the data around and give hospitals the ability to see their performance on the metrics, not only compared to what they're doing, compared to their peers, but also compared to a state baseline. And that's what we're doing. This is what they're sending us here, and we then churn the data around in a month's time and give the hospitals quarterly performance reports, how they're doing. And they use that for quality improvement efforts and so forth in the stuff. So one of the big questions when Mark and I discussed this in the beginning, he said, so how do you make sure that the hospital are not cheating? How do you make sure that they're not gaming the system? So we have another set of data. We call it the Statewide Planning and Research System. We call it SPARKS data. This is every single admission to the ER or to the hospital in the state. that the hospitals have to send us. And so when you have already like a admission data from the ER and from the hospitals, now you can compare this set of data to the clinical data and see if these both data bases match. And that was what we were doing. We also do audits on about 10% of the cases that the hospitals are sending us. And then we're using risk adjustment also, and I will go into that a little bit later. So this is a big piece, also important, the difference between clinical and administrative data. And when you see here, these are definitions, Angus and Dombrowski, that you find in the literature based on administrative data. And you see they are capturing a lot more sepsis cases than we are actually with our clinical data capturing. And it's really hard because the sepsis definition in itself is not as precise as you want to. So you have to find ways of kind of merging these two ideas together. But we feel that we are capturing much better data with the clinical data. And we did a research project, the administrative data versus the clinical data, and we found there is a 94% match. So that means that the hospitals probably are not very likely that they're cheating on, telling us cases that they think were sepsis and makes them look better, but really weren't sepsis cases. So that's a good positive thing. And then that's the first lesson. You cannot do it alone. So you need to communicate, but also bring other stakeholders in. And that's a good lesson also here in the hospital. If you just run sepsis just from the critical care folks, it's probably not going to be that successful. You've got to bring internal medicine. You've got to bring other specialties in because ER physicians, everybody, because they all touch septic patients, and you want to make it, a combined effort. So we have, our hospitals and clinicians, the advisory group. These are the two hospital associations. IPRO is one of our subcontractors who helps us with the data. And then academic partners and so forth. So all these together, form the sepsis coalition and help us to think about sepsis in general. So now I want to go into the second part, our approach. Public reporting, really, really controversial. There are big careers made in, medical research refuting efforts from states to public report. We have a long, long history, many battle scars. We are reporting since 1989 on cardiac. There are op-ed articles, physicians, even inside our cardiac advisory group. It's pretty divided that some people still think public reporting is not a good thing. But, I'm a firm believer. I work for the state, and public reporting was really number one agenda also. So public reporting means the data that we collect from the hospitals, why don't you show that to the public and have the public take a view on these data? And the second one and third, research and quality improvement, I will go in later. So let's take a look at some data. So this is, total sepsis cases. We have about 220,000 in our database now. There are about 13 to 15,000 every quarter that we are getting. Again, it's not all sepsis, it's severe sepsis and septic shock from we have about 180 hospitals in New York. And then on the pediatric side, thankfully, much fewer cases, but still, these are in our database. Then we measure something called protocol initiation. So we ask the hospital to have a protocol. So have you used your protocol in a septic patient? And this is like the data from here. You see, like from the first beginning of 2014, 73% all the way up to 86%. But that still means that 14% of the septic patients are not getting protocol treatment for various reasons, and we are looking into that, why that is. But if you break the data down a little bit different, this is now from hospital. Each number here is one of the hospitals and how they implement the protocols. You see there is a huge amount of hospitals who are, sparingly, using the protocols. But then there is a huge other, group of hospitals who are using an 80, 90, and almost, 95% of the cases. So this gives you the first hint, maybe we should concentrate on some of the hospitals here and ask, why are they not using the protocols as much as the other hospitals? On the pediatric side, there's much more variation, less pediatric cases, so there is a bigger variation in them. But again, slowly you can somewhat imagine, like also the group, the graph going up. And then let's talk about mortality. That is like the second thing that I just want to mention, raw mortality in hospitals. You heard me talking in the beginning. That's where we started, 30.2% of in-hospital 30-day mortality on the adult side. And then over quarter, it changes, but overall we are down to 24.9% now in the first quarter of 2018. On the pediatric side, again, there is much variation in there. The last quarters, it's like slightly going up again, and we are like looking into why that happens. But overall, at least on the raw mortality side, this looks good. But again, big topic, big lesson learned. Raw mortality does not tell you the whole story, because raw mortality could also mean that people are just coding more sepsis cases overall, and therefore, if you increase the denominator, the mortality goes down automatically. So never look just at raw mortality. Always ask the second question: so what's the risk-adjusted mortality for that? And I will go into that. So then we said, okay, great data, that's public reported. And we started for the first report in 2015, and we just released in the beginning of 2016 the second report on 170 hospitals. We concentrated on ER cases only. So we get cases from ER and also in hospital. 2/3 are ER cases. The big question in sepsis measurement is always time zero. When do you start the clock? You saw a 3-hour bundle. That means there's a time element to it. It's much easier to measure in the ER because you can measure when the patient walks to the door and when he was first seen. On the floor, it's much harder to identify that time zero, and this is really a hard nut to crack. We have not had a great approach yet to that, and so we concentrate in these reports just on ED cases because we wanted to at least have some reliable data on that. These are some performance measures. We concentrate on the protocol initiation and the bundles in the beginning, and this is now because we had now 2 public reports. Now you can compare 15 to 16 on some of the performance and on the raw mortality. And you see just going through one of them, the crude mortality, like from 15 overall, 27.33, went down to 25.45. This is the number of cases. These are the number of deaths. And these are 3-hour and 6-hour bundle. Then, the beauty about it is you can now look at kind of like this cluster data. These are protocol initiation. Every little circle here is a hospital. On the right-hand side here, these are hospitals that improved from 2015 to 2016. On the left-hand side are hospitals that are actually declined in performance. Upper right-hand corner is they improved and they were above the baseline, and the lower corner is they actually declined and they are below the baseline. And now you can easily like hone in on some of the hospitals and ask necessary questions. Overall, it looked great. More hospitals improved than declined, and that was and this is on the 3-hour bundle, the same methodology here. But just as an example, how you can use now data to like target your interventions or your improvement onto several hospitals. But again, the question of gaming comes up. So I mentioned that with the mortality rate. How do we make sure that hospitals now, because they know that we are measuring sepsis, that they are suddenly coding cases? If you come in with a pneumonia, they just code it as a sepsis, and therefore their mortality rate goes down and so forth. So in this paper that just came out in the Blue Journal, we actually looked at that and say, does the patient population change over time? Because if you start coding differently, the patient population overall would change over time. And these are, infections, people with infections and percentages. This is the number of comorbidities, and you see it's pretty steady. So there is no upcoding. And then, initial serum lactate and with mechanical ventilation. This all looks, there is not a big change from 2014 to 2016 when the measuring periods for. So at least in this article we found that there's really no evidence that people actually like coding more on the side, and there's some more to it. So after process measure, you always want to see outcome measure, and unfortunately the only good outcome measure is mortality. So we concentrate on crude mortality, which we already talked about on the adult and pediatric side, but then the big holy grail is a risk-adjusted mortality. And the risk-adjusted mortality now allows you to compare hospitals to each other. Before, if you just show them crude mortality, the hospitals can always say, well, my patients are actually sicker than your patients, so that's why mortality is worse. And now with the risk adjustment, you take that argument off the table. And that's actually, one of the most important things if you want to compare these factors. Estimation of probability of in-hospital mortality. We didn't take treatment into account, so we just wanted to build it based on demographics, comorbidities, and other admission characters. And it's a multivariable logistic regression model. I'm not a statistician. I cannot do that on my own. So we also had, a great collaboration with people from the University of Ohio who helped building other sepsis models for worldwide, studies and so forth. So these are some of the mortality variables that went into the model. We have to develop it every year based on the yearly data, and that's here. This is the latest on the 2016. You see here, for example, number of comorbidities. This instead of putting we put the comorbidities in itself, but also the number because we felt that would be a factor, and it showed that it was a factor. And this is probably one of the more important slides overall. So this is now the Sepsis Initiative in New York by hospital on risk-adjusted mortality. So for the first time now, you can compare every hospital with each other based on their sepsis cases. Here on the left hand, these are low-performing hospitals. The baseline is 1.0 here by definition. These have higher than the baseline risk-adjusted mortality. And here on the right hand, these are high-performing hospitals. They have a lower risk-adjusted mortality than the other hospitals. And you can see, although we are now about 2, 3, 4 years into the initiative, there is still a huge variation. What this graph tells you is if you by accident walk into a hospital in this low-performing hospitals, your risk of death is 2-3-fold higher than if you walk into these high-performing hospitals. But what it also tells you is that our goal should be helping these low-performing hospitals actually improve their risk-adjusted mortality. So in an ideal world, you want to have a flat curve that every hospital has similar risk-adjusted mortality. It will never be that. The other positive thing is we can now compare it to the year before, and we see that the curve has been gotten flatter, which is very positive, and that there are 45 high-performing hospitals versus 21 in 2015, and there are less low-performing hospitals based on the baseline. And this was, again, we omitted hospitals that had less than 10 cases because that would not be fair to the hospitals. The confidence interval, you see here, the larger the confidence interval, the less cases there are, and the smaller the confidence, the more cases there are. Again, going back to the initial question about gaming. So if now you have another tool, the risk-adjusted mortality. So if you change coding in your hospitals, your raw mortality would go down, but your risk-adjusted mortality would be flat. And we looked at that and looked at raw mortality and risk-adjusted mortality based on these circles here. And the hollow circles are the raw mortality, and the dark circles are the risk-adjusted. And you see both of them kind of follow the trend going down. And that is another point of evidence that probably this argument that hospitals are coding differently is probably not true. And that is So again, public reporting. It was, I would say, we did a press release. It was, the public responded well, but the data of people actually looking at that is actually dismal. I don't know. There are research studies of people looking at hospital performance data, and I don't know. It's like really in the low teens. How people you do not make a decision as a patient based on public reporting. But I feel that is still an element that the public should know about, and it also puts pressure on hospital administrators and also allows people such as yourself in your hospital, if you want to improve something and do change management, to argue about additional funds coming to you. So public reporting can be a powerful tool for improvement efforts, and we in New York will certainly continue to go that route. Second piece is about the research and talking about research. So one of the big issues in sepsis management is this time issue. Does time really matter, and how timely should you give certain interventions? And we worked with the group of Pittsburgh together with Chris Seymour and a bunch of other guys, and looked at this, and we had this article last year in the New York England Journal of Medicine, Time to Treatment, taking our clinical data now, because everything in our clinical database is time-stamped, and looking at what actually makes a difference in timely treatment. And these are kind of like the big take-home messages from this paper. When you look at these completion of 3-hour bundles, every hour actually counts. Every hour that you're not completing the 3-hour bundle, or every hour that it takes you longer to complete that 3-hour bundle, your mortality goes up by 4%. And that was one of the issues like last year and the years before discussed, at least in the critical care literature. Does this bundle approach and doing this bundled interventions actually help in mortality? And it was a clear yes, at least from our paper, that with every hour that passes and you're not giving all the elements of the intervention, that the mortality goes up. We looked at one of the elements of the 3-hour bundle, the antibiotics. It's also, this is one of the critical elements, that timely antibiotics actually matter. Again, every hour your mortality increases by about 4%. And then we also looked at fluids, and the fluid impact was pretty much flat. That doesn't mean that fluids are not important in sepsis. It just, had an effect we can think of that probably much sicker patients got fluid much faster than not so sick patients, and therefore, the effect overall was flat. But it had not a big impact on mortality, but antibiotic and the 3-hour bundle had. Then we also always wanted to, not only do on the adult side, but we really promoted also the pediatric side, because, you saw we only have 2,600 cases. The pediatric is always an issue. There are not so many, even in children hospitals, even in your children hospitals, I bet there are not many sepsis cases to do big studies on. But now a clinical database could actually look. And again, the question was about these timely interventions. We came up with this 1-hour bundle, and if that really makes an impact on mortality. And this is kind of like the same story that we had, and we kind of tried to replicate what we had in the other paper, that actually every hour that the 1-hour bundle is not completed, your mortality goes up. And that was, again, very powerful statement that, you should think about getting, the elements as quickly as possible. And this is a depiction of all the hospitals. This is, adjusted rate of compliance with the 1-hour bundle, and you see like a huge variation. We have about, of the almost 200 hospitals, there are about like 60 hospitals who are specialty children hospitals, but there is, a lot of variation, again, from hospitals to hospitals. And that gives us also, a lot of food for thought, thinking about quality improvement going forward. And then what just came out, in the Blue Journal about overall, the risk-adjusted mortality and the odds ratio by compliance with protocol initiated. And this graph is really about quality improvement. So if you put work in and improve your bundle compliance, 3-hour bundle compliance by 10%, your risk of mortality goes down to about 5%. And this is like pretty powerful. I have not seen data like that before. So that means that if you improve your processes around that, you really will make an impact on mortality. The effect is even bigger on the 6-hour bundle, but this is another piece of information that gives you the tools and probably the data around improvement and quality improvement on the sepsis side. And then we work on other things. I'm very interested in racial and ethnic disparities, not only on sepsis but other pieces, but we look in sepsis as well. So if we make improvement in mortality from hospitals, do all hospitals look the same, or are there certain hospitals that improve much better or much worse than other hospitals? And thinking about racial and ethnic disparities. Readmission, huge point, because very important. There are a couple papers out there that the readmission rate from a sepsis episode is, up to 25%. Who comes back, and can you identify these readmitted patients earlier to make, to give them better care or better follow-up in the outpatient world? And then broader national and statewide trends in sepsis mortality. One of the big questions that is still not answered to this day, if this mandated protocols that we put in by regulation in New York State really made an impact in New York. Because you have to look at other states as well, because the mortality rate overall in sepsis is slowly going down. So with our mandated regulations, did actually the slope of the mortality downwards go further down or not? And this is a question that we cannot answer by New York alone, so you have to look at other states. And there is a research collaborative with 6 other states, New Jersey, Connecticut, Massachusetts, Florida, and 2 others, I always forget them. But they will now compare, and these states don't have sepsis protocols versus New York, who mandates sepsis protocols, and compare, the rate of improvement in deaths over time. And I saw some preliminary data, and it's pretty amazing that actually, the regulation that we put in place, there's a huge suddenly drop in mortality, and that holds true now over the next 1 or 2 years. So that will come out pretty, by the end of the year, hopefully. But that is, one of the big questions. And then, hopefully, Illinois and New Jersey have just enacted regulation as well. And, there are groups like the Rory Staunton Foundation who are advocating for making sepsis protocol mandatory in all the states. But this is interesting. And also, on the broader international level, we talk to folks from Germany and also from the WHO. So how do we do in America on sepsis? Nobody actually knows. And how do we compare in our treatment and our approach? And that is also... I'm also interested in maternal mortality. As you know, that the maternal mortality, at least in New York, is horrible. And sepsis plays a role there. And so we are looking at cases from there. And also in post-acute care, that goes to the readmissions, but also we have other data sources where we have functional assessment from people in nursing homes, and now you can imagine combining that with our clinical database. So you have a functional assessment in a nursing home, and then the patient gets admitted with a septic episode, and then goes back to the nursing home and has another functional assessment, every month, and you can now compare how these people are doing in the community. Very interesting stuff. So again, research might hold the key to future improvement. You can pinpoint and target some of your quality improvement initiatives around the research, and that is certainly kind of the next step to take to look at the data and look at the research. And then the last point is quality improvement. So we're working on many fronts. Unfortunately, like the Department of Health, although we have many people, in my group, I only have 4 people, so we cannot do a whole lot on our own. So we have to collaborate with different people inside and outside the department. But there's a huge, as I showed you in the data, huge opportunity to improve and save life. thinking about clinical practice and delivery systems. So what actually works better in which subpopulation? That's another big question in sepsis. We are working with CMS. As you know, CMS has a sepsis measure. They came after us, but we are collaborating with them and thinking about aligning more on what they're doing and we are doing. And then relationships between the protocol adherence and certain interventions. Development of relevant outcome measures for children, another piece. Like mortality in children is probably not like a good outcome measure, and there are other approaches now on the national level, and we are talking with some national groups about this if we can help with that. And then collaboration. There is a big Partnership for Patients grant from CMS that the hospital associations receive, and so we're giving them data and work with these, what I showed you on that risk adjustment piece with these low-performing hospitals, and bring in high performers and say, so what are you doing different than the low performers? And so we can all learn on that. And then one of my big pieces is making data available for research. This is kind of, when I came to the department 2.5 years ago, it was like I couldn't understand why, they're sitting on so much data. Why do they not share the data with the research community? And so I had to really fight like an uphill battle. But we finally have everything approved. There's a process in place now how you can get access now to New York State sepsis data because there is such a need for saving lives, but also for answer a lot of crucial questions that I cannot come up with and I don't have the time. So why not collaborate with outside researchers making the data available? And we are going to do that. There's also an initiative from Governor Cuomo in New York about data transparency. They call it Open Data New York. So we will make a set of sepsis data available. This is not really for research. This is just like too high level, but at least having people, if you want to just look a quick look about sepsis in New York, you can go in, download a spreadsheet, and see how the hospitals are doing in New York. So where are we? I mentioned at the beginning this lofty goal, reducing the mortality by 50%. We like overall, I calculated out, we reduced it by about 15%, so we are not even halfway there with all the advancements that we did so far. I know that additional gains will be harder. The low-hanging fruit, that's the long story about quality improvement. In the beginning, it's pretty easy to make gains, but other gains will be harder. And it probably needs a lot of research and data to make further improvements. And then, of course, you cannot do it alone in collaboration with national partners to bring further gains. So we have still a long way to go, but I think we are on a right track of tackling the question and hopefully reducing the mortality. And that's it for me. Thank you very much.
Well, thank you very much. So we're going to open to questions. Connor's model of transformational change is near and dear to my heart. That's what we used for our transformational change in primary care. And I think one thing we've done here at UW is really been transparent with data, which I think is also a core value of us, which really matches the work you're doing. So questions from the audience. If you could stand up, and when you ask your question, can you repeat it for the microphone?
Yes. Go ahead, sir. Yeah, and I think, so just to repeat, so the question was about, the difference in time from recognition until, you start the action and start actually, the interventions and making sure that this is, recognized. And you're pointing out that's like the holy grail of, when do you recognize, and how do you make sure that the recognition in itself is valid enough that would trigger then all the interventions at a timely fashion. And I think that is, we are working on that to help hospital to identify that. We cannot be descriptive in that. We want to help with solutions and show how this can be done, but every hospital process is different from hospital A to hospital B, and I feel that you have to take into account the culture in the hospital, and you have to come up with individual solutions for bridging that time gap. But this is exactly, I think, a well pointed out issue that you have to make sure that not only you recognize it, but that the actions follow very quickly after the recognition and closing that time gap. Yeah, that is probably an approach, but the academic sepsis researchers, they cannot even align around a sepsis definition. So what is the right protocol? And I don't think that the data already shows this is the right stuff. We're getting closer to it, but I don't think that we yet have recognized this is the final protocol that everybody should use, because it depends on, and I always compare New York as such a diverse state, like 60% of the care is done in New York City, and then 40%, the rest is spread over, a huge area in New York. So what might work in New York in a highly academic hospital in the ER might not work in an emergency room, somewhere in Syracuse in a rural area. And so you have to take these into account. And therefore, I do not feel that the department should go out and say, yes, this is the right protocol that you need to install.
Another question?
Go ahead.
So to the point that it's somewhat difficult to determine who has sepsis and who doesn't, right? Most of this data is looking at people where they feel confident retrospectively were septic. What do you make of the criticism that folks who are not feeling septic are getting inappropriately exposed to antibiotics and causing harm by this sort of aggressive early intervention?
Yeah, no, it's another. So the question is, if I can just sum it up, antibiotic stewardship and how you make sure that you're not causing any harm by giving unnecessary care to people who don't really need it. So we are working really close with the antibiotic stewardship. I was just on Wednesday at a talk where somebody, brought up that argument about that ER physicians were really hesitant of installing sepsis protocol in the ER because the ID folks always, were beating them up and saying, you have to watch out, don't give antibiotics to everybody. And so I think the right approach is you have to first of all, I feel that antibiotics can reduce the mortality if you take that into account, but a quick de-escalation if you're feeling that you're not on the right path is probably appropriate. There is also, or was a question in New York, for example, with flu. So how do you distinguish between sepsis and flu, and do you want us to give antibiotics to flu death? We actually looked at data, and there is a lot of co-infections. So you can have the flu, but also an infection at the same time. And I always argue from the place that if you're wrong, you have probably given unnecessary antibiotic. But if you're if you're not doing that, the mortality rate is so high. And we saw, and I looked over the pediatric flu deaths over the last winter. We had a lot of, big flu epidemic in New York. And in 9 of the 10 cases, antibiotics were not given, although it turned out later that there was a, flu plus infection. And so I'm very cognizant of the fact that too much antibiotic is bad, but if you're not 100% sure, I would rather pick the antibiotics than miss the antibiotics and then have a septic shock patients and then not further going down.
Thank you for sharing this remarkable story. I mean, it's just got to be so pleasing for you to see what's happening throughout the state.
thank you. It's another great question. So 15% of all our cases are transfer cases, and we capture the initiation hospital of the transfer, and we also capture the receiving hospital of the transfer. There's a lot of research done. There is the smaller hospitals are transferring patients. There is one of these ideas behind that most of the hospitals are transferring the patients too late when they are already in so critical condition. So they get in the big receiving hospitals, they get patients who are already very sick. We feel that we need to look into that much more because that is a crucial issue, especially on the pediatric side as well. Most rural hospitals send in their pediatric patients to that. And there is much more to be done on that. I do not have good data now to show you about the transfer, but this is an upcoming issue. For example, for the public report, we omit all transfers because you cannot be 100% sure how you treat the sending hospital and how you treat the receiving hospitals. Who did the right intervention at one point. So we didn't want to go into that argument, so we just omitted all the transfer cases, at least for the public report. But we are actively looking at this. One of the issues that we found that there is coding, very interesting coding. So some of the sending hospitals do not code it as sepsis. So they just say, we are sending a patient to you with pneumonia, although it's clearly a septic patient when he arrives at the other hospital. And so that is one of the issues. And we can compare that with our Sparks data. We can see how many hospitals are coding. So that is one of the issues that we want to try to address, that we just make sure that they are coding it correctly so the other hospitals is aware that there's actually a septic patient coming and not just a normal pneumonia or something like that.
You might be able to tell us whether it's good to transfer or
Yeah.
not good to transfer.
Yeah, and that will be hopefully coming in.
Given that time is such an important variable, do you guys have any data on the average transit time to different hospitals, like for ambulances? Maybe people who, I know I had a primary care client here. I had a patient whose brother had a heart attack, and he drove to the ED because he knew it was going to be an hour and a half to the ambulance.
Yeah.
So, do you guys have any data on that?
Right. Yeah, no, another great. I work also with the cardiac side, and we just looked at regional differences and transfer times for STEMI and NSTEMI, and the different ways or looking at mortality. We have not done that in sepsis, and I think that is one of the next holy grails. The University of Pittsburgh, they're actually working on this, pre-hospital and emergency room data piece and evaluating if there is a need for, first responders to even do some interventions already in the ambulance, like giving fluids or, giving a broad spectrum antibiotic. We have not. We have data on trends on the ambulance time, but we have not connected that to the sepsis piece. But I think that is clearly same as on the cardiac side. That is kind of the next holy grail. And on the cardiac side, there are many instances as well, because we in our cardiac database we do not capture actually how the patient got to the hospital, and that is probably one of the issues, that some people are just being put in a car, sent an hour away, and others go with an ambulance, and they already have some kind of care in the ambulance, and these people are probably doing a little bit better, I can imagine, but much more to be done.
One more question?
No, we wanted to really hang it or develop the model around the patient, and then you could then look at hospital characteristic and see does some of this correlate with increase in mortality, and that is certainly the next step. But we have not taken hospital pieces into account.
Dr. Jekyll, I will let you wrap it up.
Oh, thank you. Okay, so just doing the risk-adjusted equivalent reporting mortality is a huge endeavor.
it's a good question. It's, I think, too early to tell because we just have like 2 years. We're working on the 3rd year right now, and then we would have like 3 data points for these poor performing hospitals. But there is some pressure because we send actually the public report direct to the boards and to the CEOs of the hospital. So some people will look at that and say, well, our hospital is not performing adequately. And we heard anecdotally that there are funds being made available for these hospitals. And one of the payers, Medicaid, had a pot of money that they actually incentivized some of the low-performing hospitals to do better on a variety of measures. But sepsis 3-hour bundle was one of them to actually improve their outcomes and their process measures. And so, this is like a step. And I can only speculate, CMS as well, by looking at their own data. Eventually, they will, same as with readmission, it's on the same path to being evaluated as maybe being tied to payment in the future on some of the issues.
Well, I think what is so inspirational about this project from my perspective is those of you who are interested in quality improvement and wondering how does that intersect with the academic enterprise, with rigorous study, with changing lives. This is a great model for that, and you're going to help us to know the right answers to some of these things. So, and I think there were very sophisticated questions from the audience, which means like we're really thinking about this world as well, which I think is fabulous. So thank you very much.
Thank you. Thank you very much.
That was just inspiring. I just loved it. And I am such a lover of Cotter. And, so...
I didn't know if I should put it actually on
no.
there.
So when